Hello and welcome to this week's episode of the Science or Fiction podcast, the podcast where we interview experts to separate the science from the fiction in headlines and media coverage of psychology and mental health. I'm your host, Dr. Catherine Bates. I'm a Youth Development and Mental Health Research Fellow at King's College London, and this is the Science or Fiction podcast. This episode is the first of a two-part series where we're going to be exploring how people experience chronic pain and why there are inequalities in healthcare, and a new programme designed to tackle these inequalities and improve outcomes for people with chronic pain. Chronic pain is experienced by around 34% of adults in the UK, and it affects roughly 1 in 9 young people worldwide. Pain is defined as a negative sensory and emotional experience. It can impact all areas of life, and many individuals experience mental health difficulties as well. Chronic pain is where this experience persists for 3 months or more. Not everyone experiences chronic pain in the same way, and inequalities in healthcare can make it even more difficult for some individuals to get the support that they need. Today we're talking to Dr. Anna Hood, a chronic pain expert based at the University of Manchester, specialising in young people's experiences of chronic pain. So hi, Anna. Welcome to the podcast. Thanks for coming.
Hi, thank you. So excited to be here.
First, before we get into it, I think it's always interesting to know a bit more about what you do and how you got there. So can you tell us about your job and maybe like an unexpected detour that led you there?
Yeah, so I am a lecturer in psychology at the University of Manchester, as you mentioned. I am also a clinical psychologist by training, so registered here in the UK to be able to treat clinically. Lots and lots of detours. So I would say anybody going into training, there's always places where it might change. So I'm originally from the UK, grew up in Birmingham, but actually moved to the US as a young adult, actually, and not to initially for education. And so worked in hospitality for quite a long time, and then decided I wanted to go back and seek my PhD. And sort of over time realized that I wanted to have a strong research focus in addition to be able to get that clinical training. So I wanted to be able to be a researcher who had experience of sitting in front of somebody who's experienced depression and anxiety or a chronic illness and how that manifests for them. So I actually lived all over the US, but did a lot of my training in the middle of the country. And that's where I started doing work with children and young people living with sickle cell. Sickle cell's a red blood disorder, but one of the primary hallmarks of it is the experience of pain, both acute, which acute just means that it can sort of happen at any point. There can be different triggers, but also that can lead into chronic pain. And about 40% of people with sickle cell as children then go on to develop chronic pain as well. So they have these two types of pain. And so I was really working with that population a long time, and then started to think about, and actually the detour that you mentioned is that I was invited to a patient conference. So it was completely led by people living with sickle cell. And I was going and talking about psychological outcomes, actually. And people were lovely. But at the end of almost all of our talks, people were talking about their experience of pain, the fact that they weren't getting the treatment and care that they wanted. And they thought that that was in part based because people with sickle cell have darker skin color. And so it's a disease of ancestry. So most people are of African or Caribbean descent. And so that was my unexpected detour. It sort of changed where I wanted to be doing my research. And so I sort of continued working with that population, but shifted into more of treatment care. How do we make justice pathways for people to be able to seek and get back the care that everybody should be able to experience? And so that's what I've been doing really over these past 8 years or so. Moved back to the UK. So I was in London, based at University College London. And then since 2021, have been here at the University of Manchester.
Brilliant. Thank you. That sounds like such important work. And it's always nice to hear when there's a bit bit of a detour. I think when I was finishing my undergrad, I definitely felt the panic of like, I need to know what I'm doing and be on the right track or whatever. But no, you can also move to the US and work in hospitality for a bit. Why not?
Yeah, I actually worked really detouring. So I worked on a cruise ship for a long time, and I wanted to travel. And so I did first. So yeah, you don't have to. And I think actually it's helped because I come in with sort of slightly different perspectives, but yeah, and I think having people from lots of different perspectives is really good. So some people who come straight from undergrad, some people who, maybe take a detour. I think having everybody with all those different experiences is a really good thing.
Yeah, 100%. I agree. So you touched on it a little bit, explained that there's kind of acute pain, also chronic pain. So how can it impact a person's day-to-day life? Is it affecting, it seems like something that is a different experience for everyone.
Yeah, I mean, if you think about what chronic pain could look like, and actually the numbers for your children and young people are slightly higher than what you mentioned in your intro. So we have a recent study showing that nearly 1 in 4 kids, actually, young
Oh,
people,
wow.
children and young people, are experiencing chronic pain now. So it's really this explosion in what we're seeing in chronic pain and in suffering, right? In experiencing it.
Mm.
And so, your listeners may have heard of things like fibromyalgia, and obviously there's headaches. We've got, severe menstrual pain when we think about young women. But so it can come in all these different ways, be it, the location of the pain, the intensity of the pain, the amount it interferes with daily living, can have all of these different types of effects. And, some of the things we do working through, in psychology is for people to manage and maintain that. But yeah, chronic pain essentially can be debilitating for some individuals,
Mm.
meaning that there can be some days when you sort of can't get out of bed, or it's difficult to leave your home. Other days where you're able to push through and live the life that you want to live. And so that's the different fluctuations, and those different fluctuations can look different for each individual.
As you were giving those examples, I was suddenly thinking of like lots of people that I know would actually fall into that category, and that like never really occurred to me before, which I think is the whole point of kind of having these conversations and learning a bit more about it.
Yeah, and I think that's why the numbers are higher. So if we think about chronic pain, pain lasting, longer three months, interfering with
Mm.
daily living, yeah, once you start thinking about it like that, right, you can understand that lots of people are just sort of being told just to push through. And that's sort of some of the work
Mm.
that I have to do, especially more recently, is that I think one of the biggest challenges with chronic pain is that we've all experienced pain. It's a universal experience, and there's not a person who's here who hasn't experienced pain. And yet, dismissal or denial that somebody's experiencing chronic pain is often the thing they're first met with when they share that they're experiencing pain. And so how do we do better, I think, both as researchers, but as clinicians and all of the different specialities, to make that experience better for individuals? Because it's already, I hate that sometimes the first thing somebody experiences is a dismissal, because I don't know why somebody would lie about experiencing chronic pain. There's a few secondary gains, but I don't think that should be the thing that we're focused on.
Mm.
Most people, if we've got 1 in 4 people experiencing chronic pain, then we should be opening our minds in that this is their experience, and how do we get them to a life that they want to be able to live. And sometimes that's not
Mm-hmm.
a life without chronic pain. Unfortunately, we're not there yet. But it doesn't mean that it can't be a life that they want to live.
This is something that I wanted to ask you about because we often see in the media, for example, there was an article in the BBC last year that was titled, "I hid my pain from loved ones for 25 years." And you touched on some of those issues there. And also in the second episode that's coming out on this, Misha Gardner talked about how some of the people that she was working with, they just found it so traumatizing to have to explain their pain every single time they needed support, or every healthcare professional they came across. And it's just that trying to like convince people, but often not physically obvious, that you're experiencing pain. So I guess my question is like, what might which we've kind of touched on, but what might lead people to feel like they need to hide their pain, or how can we make it easier to talk about?
Yeah, I think I've got a couple of things to respond to. So first, in thinking about like the fact that in the media, for the most part, and this is some work that colleagues and I done, it was actually some of it led out of the University of Calgary with some support from researchers at the University of Bath. But thinking about what in the media, what does pain actually look like? And it doesn't actually look like chronic pain most often, right? It is most that acute pain. Somebody's just experienced pain. And that pain, we are told, is curable and we're supposed to get over it, right? So that's the message that we are receiving. Pain happens, yes, to all of us, but it's happening for a finite amount of time. And then once you've experienced it, then, you'll take medications, you'll do physio, and it will go away. And that isn't, and so that's one type of pain. And I don't think we do a good job of talking about the experience of chronic pain, because chronic pain is something that happens over time. It seeps into lots of different parts of an individual's life. It takes things away from what you're able to do. And so we need to do a better job of understanding and sharing what chronic pain looks like, so people don't feel that they are not normal or abnormal, because pain, I'm supposed to be better now, is the experience that we're told. And chronic pain doesn't always look like that, of those experiences. Some of the other reasons that somebody might want to hide it, you touched upon, is the trauma of having to explain over and over again and convince somebody that you're experiencing pain. One of the things we know is that pain is subjective, so it's harder for individuals to, even clinicians and healthcare providers, to be able to say, this is the definitive thing. I'm going to give you this definitive test. It's going to tell me this is the thing, and then I'm going to give you the medication or the treatment that you need. It's just more complex than that. And so you're always having to give your subjective experience, and that can be in itself traumatizing. And it can be particularly traumatizing if you give that experience and then you're not believed. I'm lucky enough to work with both children and young people and adults with lived experience of pain, who have said that the biggest thing that has helped them is just when they come in and the first thing somebody says is, I believe you. And it's simple as that, because they've been through. So Ken, who's one of the people who lived experience, his story always resonates with me. He had a car accident at 16, hugely severe car accident, huge abdominal injury. That was his worst pain imaginable. And then went on to has had chronic pain for many years since. In those years, it took 15 years till somebody said they believed his pain. Now he was awful. Right, he was in a car crash, right? And so he said he couldn't. He said he didn't realize until somebody said it to him how much it would mean to him. That was the first experience. And so that's why I talk. So that's a lot of the research we're doing and the work with clinicians. I think some of this work is with clinicians, not even with people who lived experience of pain. It's sharing that, making this a safe place for people to talk about things that are psychologically challenging, and saying you believe them, saying, maybe we're not going to be able to solve that chronic pain right today, but I'm going to work towards getting you to be, where you want to be. And like, as I said, sometimes that might be living with chronic pain. So that's the reason people might hide it, is because, they're not experiencing a pain that they have seen and know this is their pain's different. And why isn't it getting better? Is it something to do with me? Like, that's the experience, right? I'm doing something wrong, so I'm not going to share it. And then when they do share it, not always being believed, and feeling that dismissal. And I think one of the big challenges we also have in all of healthcare, but with pain comes that subjective piece, is that we have these different levels of inequality. So a lot of our chronic pain conditions affect women differently, and we see higher prevalence of women, and they already struggle to receive pain treatment. One of the things I always say is, it sometimes blows my mind that our idea for menstrual pain is just live with it and maybe take some paracetamol, right? And I can't imagine that if that was reversed, if it was when experiencing that would be our our only treatment in 2025, really, of like, this is just for the majority of women, just suck it up, right? is
Yeah.
the idea for it. And so, and then those levels of inequity grow depending on different intersectionalities. So if you come from a more deprived background, if you are from a minoritized community, and adding some of those different things in, even being able to seek care that is appropriate for pain. So pain clinics aren't everywhere. So there's, large pain clinics in our big centres, in Manchester, in London, in Birmingham. But if you live outside of those areas, where can you seek treatment? So it's just really there's just a lot of reasons that people might want to hide it, both specific to themselves and specific to their surroundings. But I think there are ways that we can make chronic pain more visible, I think, and do better at making people feel more safe when they discuss it.
Yeah, and like you said at the start, it seems to be about moving away from this kind of medical approach where you're just we can define it this way and we can treat it with this one thing, and instead, with the example that you gave, you need to consider the social, the psychological, the believing in people. It's all of those elements in order to firstly understand someone's pain and then be able to support it as well.
Definitely. I mean, so what we have in pain, our sort of gold standard model is thinking about the biopsychosocial. So the biology is there, psychology is a huge component, and then the social. What I'll say is that for GPs or in more rural areas, that isn't always the case. People haven't had that biopsychosocial model training, and so we'll fall back onto their training, which is that biomedical model. I think also and some work that, colleagues and I are doing are thinking about the structural as well. So like I said, the actual systems and how they work. But we actually still, even with the biopsychosocial model, don't, I think, do enough on the social. I think my colleagues who are healthcare providers feel more comfortable maybe with the psychological. That is maybe understanding it's happening. A part of what we can do to treat it is changing the way, people's thoughts and cognitions. And that is very much true, but that also sits within the social system and how individuals are able to do that. And so really what we want is, all individuals who are treating people with pain to think about the biopsychosocial. And as I said, I think adding structural in there as well, so that we aren't really focusing for the majority on the bio and then sometimes on the psychological, but not really thinking about how people sit in social systems and how that just has huge effects on what we're able to do.
Thinking of some of the structural issues and the systems, you wrote a really powerful article for the British Medical Journal this year, which I will link in the notes, titled "Racism in Pain Management Causes Needless Suffering." I wonder if you can talk us through some of those key issues that were important to raise there.
Yeah, so I was happy to write that opinion because there are many scholars who've done this work for decades, I think, in showing that there are differences, disparities, which is just a fancy word for differences, between different groups. And what we know is that for individuals, a lot of this work has been done in the US, I will say. So particularly showing that Black and African Americans have different pain outcomes to their, white counterparts. And that was really important work for us to be able to do. Because we can show that these differences. And now, though, we want to show what is actually driving those differences. Because, right, race is social, right? It's a social construct. It's something we've created. There isn't a biological difference between individuals from different races. So South Asian individuals from Bangladeshi and Pakistani groups and Black groups in the UK is what we see. These big differences in pain as well, and across a lot of different health outcomes. And so it's social. So what is the social driver that is causing this? And racism and the experiences of racism are one of those social drivers, and a large social driver for when individuals, so the young people I work with sickle cell, they only go to the A&E when they're in their absolute worst pain. because they don't want to be called drug seekers. Right? They get told that, why do you know so much about your medication? Like, because they've worked with people who, like me, who say that's important. Self-management, understanding your condition is important to know. But that comes back because of this subjective experience and unconscious, oftentimes, biases and discrimination that go in to seeing an individual, a young Black person coming in and saying they're experiencing pain and want drugs for it. And so the drivers of what are important, and then we can work to eliminate those drivers, and that's the only way we can do it. And so the work that myself and colleagues have been doing more recently is building on that, and that's what the opinion piece talks about, is that people are suffering, are not going in to seek care. When they do, they're going in their worst pain. Then they're having these traumatizing experiences because they're not being believed because of their pain. If they are hospitalized, they are experiencing challenges, and racism is one of the pieces that can go into that and have that effect. And this, like, as I said, this isn't always, I think oftentimes people can think of racism only in one way, that one person in front of another person and maybe a slur or a microaggression, and that isn't the only way that it can manifest. It manifests in the fact that young children who have a broken arm, who go into the emergency rooms this is research that's been done in the US, if they're Black children, they'll get different medications. So they'll get different types of analgesia, so that's pain relief, than what young white children, even if so they've both got bone fractures, but they'll get different medications. Black children who have had appendicitis, so these real clear indications of pain, will wait longer to get treatment for their pain. This isn't something people are doing, right? So this isn't something somebody's saying to somebody. These are just unconscious things, and when you build it in, then it can have these large outcomes. And we see it here in the UK in our adult populations. There's been less work on our kids, but we see it in the adult populations as well. And with our sickle cell, we've had some recent reports, like an ambulatory report, so in London, that is really trying to change their services because people weren't using the ambulance service who had sickle cell for their pain, because they were they didn't feel they were getting the treatment and care they needed, and the ambulance service is realizing that and making changes. So there is ways to change. It is sort of letting go and thinking there isn't only one way that racism manifests. It manifests in these small, insidious ways that can build and then mean that individuals will no longer try and seek care. And then when they seek care and get care, we see outcomes. So it isn't. Yeah. So we know. So it's clearly that it is something that's social.
So important to raise, because it just shows that the psychological is just not enough. Like, we can teach people or help people advocate for themselves and be able to take themselves forward and recognize their pain. But if there's not changes in these structural issues that are underlying it, then you're not going to solve the problem. People are not going to get the care that they need.
And you couldn't have said it better. I think, we do a lot of work as psychologists. So I did some of my training where I was inpatient, worked with inpatients in a hospital. So when they would come in, I would see them, and if they were experiencing pain, I'd go and see them. And as a psychologist, I would work with them to do some strategies with what their experience of pain. So for young people, it's on your phone, right? Right? Well, can I play a game? Is there somebody I can talk to who can't be here? But then later on, I would see in the notes that, well, they're not experiencing as much pain. This would be because they're on their phone. And I would have to say, no, it's a strategy. That's actually a psychological strategy. Distraction is a strategy for pain. And so, as you mentioned, so you can give somebody a strategy, but you've also got to change the system so that they understand that this is a strategy somebody's using. And so if I'm asking them, to play a game when it's happening, or somebody's coming in to change their IV line or something, and that's painful, what can we do? Like, how can you the person can't be there, so let's talk to somebody on the phone. You can't have that then used against them in some way, and then saying they're not experiencing the pain. The hope is their pain did go down because we gave them a psychological strategy. So you can't have the psych without the system change, because then they rub up against each other.
I'm going to try and pivot towards strategies now. One of the listener questions, they were asking about treatment, and this also kind of ties into a question that came up for me when I had the other chronic pain conversation with Misha. So I'll start with the listener question. They asked basically, does CBD help for chronic pain? I should also say that by CBD we mean cannabis oil.
That's a really interesting question. So we haven't published this data, but a couple of years ago, I worked with an amputation population who are experiencing pain, and asked them about CBD. Actually, specifically about their experiences of CBD. These were older adults, because most of less people with amputation were younger adults. But what was really interesting was the idea first is that not knowing, what type, whether it works, whether it doesn't work. And so some of the evidence suggests that CBD sort of in clinical trials, large scale clinical trials, doesn't have that large an effect. But what I'll tell you is in the studies that I've read and that I've conducted myself is that some people will say it's had a huge effect for them. And so one of the things that I advocate for is if individuals have treatments that CBD, but also treatments that fit for them culturally, that are outside of our normal psych and medical evidence base, that aren't harmful to them, then why wouldn't we support individuals using those? Because to be honest, if something's working for somebody, it doesn't, no point taking it away just because something else says it might not work. And so one of the interesting things that came from that study was that the individuals who were using CBD didn't mention it to their medical providers because for some of those reasons. And so they didn't know how to bring that conversation up, and they would love to have had that conversation with their medical providers because they wanted to know what was safe, like, what was dosing. So the ones we were talking about were topical. So putting them actually rubbing them as creams into the affected area rather than taking any type of pills. But some people were doing that as well. And some people, were smoking marijuana. But whether it's a complicated answer in that I would say our large-scale clinical trials would suggest that no, overall there aren't these big differences between two different groups. But what I'll tell you, having conversations with individuals who have experienced pain, is that it varies. Is that some individuals will have very little effects, but some people will have large effects. And so whatever's making sure it is taken safely, trying to have that conversation with your medical provider. But if it works for individuals, just like acupuncture will work for some individuals and not work for other individuals. For my young people with sickle cell, massage works very well. Might work for somebody, physio we know works very well for a lot of people. So it's working out sort of, I don't think there is a one size fits all. It's like what part of this, hopefully what will happen, I would hope, is that we have these these different treatments for pain, and go to a young person and then say, well, what do you think would fit with you? Just like I do when I work with somebody who's living with depression and I want them to get out of the house. And because we know that, as you know, doing things when you're experiencing depression helps. Doing less makes you those symptoms worse. I wouldn't be suggesting as treatments things that I think are things you should do to get out of the house if they're things that you're never going to do. Right? They aren't activities that you can afford or want to do as a young person. So I am guided by you. So I think part of that is what we should be doing as well, is like, these are the different types of treatment that work well for different individuals with chronic pain. Like, what things do you think would fit with you, your lifestyle? How can we incorporate some of these things into your treatment package in addition to likely medication as well?
Yeah, I think that's really helpful to know, because I think it's I think it's just helpful to hear that it's not just one size fits all, and if something is safe and if that you think it's going to work for you, then it's probably worth a try. So it kind of ties into something that came up from the chronic pain healthcare program that Misha told us about, was the importance of individuals understanding or thinking about the mind and body connection when dealing with chronic pain. So like, yeah, basically not seeing them as two separate entities. And I guess it kind of plays into the strategies a little bit as well. But I wondered, kind of from your research perspective, could you tell us a bit about like the science behind like the relationship between psychological and your brain, and why that might be important when you're trying to deal with chronic pain?
Yeah, I mean, if we think about it, for anything that we do, we have a thought about it, right? So, and then that affects the behaviors that we do, right? And so, for chronic pain, there is, or really any type of pain, we have a cognition or a thought about what that pain might be. So something's happening in our body, and then our brain, our mind is giving us some signal about what that might mean. And with pain, it's challenging, right? Because again, the goal normally for pain is to tell you that there's something wrong. Like there's constant, but with chronic pain, you're getting those experiences that something's wrong, but it continues, right? And so then that's the challenge with the mind, because it's like telling you should be doing something differently. And with chronic pain, one of the big challenges it can be telling you is just don't do anything, don't stop doing things, which you should be doing for acute pain. Like, if you are cooking something and the pan goes on your hand and you experience pain, you need to take the pan off, right? But with the chronic pain, your mind's giving you some of those signals, but what we actually need to do is what we know is doing more. Again, just like I said with depression, doing more, continuing to engage in activities you enjoy that you did. So if walking, playing with your younger siblings, if you're a young adult, hanging out with friends, all of those things actually help with the experience of chronic pain, even though sometimes your body and your mind aren't matched up. So that's one of the things in research that we do a lot of, is understanding how the signals that people are experiencing can be interpreted in a way that makes sense for certain types of pain, but not for the experience of longer, persistent and ongoing pain.
I imagine that's just really hard to do in practice as well, isn't it? Because I imagine if you're feeling like that, your go-to is to try and like be comfortable and maybe rely on some of those like not moving kind of thing. And you kind of have, yeah, it sounds like you have to train yourself to think differently when it's ongoing pain.
Yeah, definitely. You have to start, and sometimes you won't, and having the grace with yourself to be okay that sometimes you don't always do the thing. None of us always do the thing we're supposed to, right? We still eat the thing, you eat the cheeseburger when you're not supposed to. So that continues, that doesn't change when you're experiencing chronic pain. So it's giving yourself a bit of grace, but then also knowing that, it's really trying to tie. What I do a lot of is trying to tie that to things that people already enjoy. Like you don't want, because that separation for anything, then that's why we see individuals who are experiencing chronic pain have higher rates of anxiety and depression, because you can no longer do the things that brought you joy, that gave you connection, that gave you belonging. All of those things, as might be taken away from you. And so yeah, it's also, like you said, sort of retraining yourself, retraining your brain to say, I can still do those things, even though it sometimes hurts a little bit, right, when I'm doing them. But I'm going to keep moving and keep doing those things. And that's one of our psychological therapies around that is called acceptance and commitment therapy. And sort of that is sort of accepting that this is who I am now, and just committing and continuing to do the things you enjoy. And as you mentioned, CBT, so that's a cognitive behavioral therapy. Those are those thoughts and cognition. And so different psychologists will work with different people using different treatment types. Again, it's not always that one size fits all, but it's working with individuals to think, well, and that's part of research that we do, is sort of what bits of which things work for different individuals.
If someone is kind of listening to this episode and thinks, do you know what, I've been living with pain for a really long time and I hadn't really realized that wasn't normal until listening to this, where do I go first? Like, what would you recommend?
So I think if individuals, I would go to see their GP, because that's still going to be the first line. And I think explaining, that, pain has been happening for a longer period, just talking about that experience of pain. But then you can get, there are opportunities to get referrals. There are larger pain clinics. And so if that pain's ongoing and it's not, what the GP is able to offer isn't working for you, asking to go to specialist clinics where we have psychologists, physiotherapists, medical providers, all there working in large teams to help individuals. I would share, if you have not spoken about it to people who love you and who you love, I would share it with them. It's just to be open about it and it being okay that you're a person living with chronic pain. There are a lot of different types of groups and support groups out there now, and I think a lot of people find comfort in those. So be it either on social media or on other ways to connect with groups. So again, GPs or pain clinics can link you into those. So if that's a way to build a community, so to know that other people are experiencing similar things, because I think the young people I know who've later joined groups like that are like, oh, I just thought it was me, or because there's nobody else around you who's experiencing that. I didn't realize that could be a normal life, and then seeing people who are experiencing pain but continuing to do things that they enjoy. So I think seeking medical treatment, getting additional medical treatment if beyond GPs if you can, and then sharing with your loved ones, and then trying to build a community and other people with chronic pain, because there's a lot of people, as we said, there's a lot of people out there, and I think it's what I've found is it's a really supportive community. People really wrap around each other.
Is it also important to recognize that chronic pain can fluctuate? So I imagine what could happen is you've experienced pain, I guess, most of the time for someone. They might book a GP appointment that they couldn't get for 3 weeks. And then on that day, they're kind of like having a good day. And then you might feel a bit like, oh, well, now what do I say? Or how should people kind of manage that? Are fluctuations normal, essentially?
Definitely. Fluctuations are completely normal. And, because you'll have days where you can do lots of the things you want to be able to do. And then other days where it's, like, as I said, completely debilitating and it's difficult to leave the house. And so, yeah, it's okay that if the medical appointment you have, some people, depending on, again, different for different individuals, some people note things down. So use a little bit, maybe like a diary, either, paper and pencil or on their phones. There are apps, obviously, that you can monitor. So if you're worried a little bit that people won't believe you or that you won't remember, because I don't think I mentioned this earlier, pain has effects on our brain, such as our memory, our different thinking abilities. So sometimes you might want to note that down in the moment. So some individuals do that for themselves so they can know, and then take it to medical providers and say, even though I'm not experienced today, 2 weeks ago, like I couldn't do all these things. This was my pain. And so there's been a lot of work with children and people trying to use those digital tools so that individuals can feel a little bit more management around it and know when to include those treatments. But for somebody who's just starting off, that might be a really good way to understand, right? Like, because maybe you don't even believe it yourself yet that you're experiencing chronic pain. If you start noting that down and seeing, oh no, this is happening more than I even thought, and then you, like I said, you've got that history that you can then take to the to your GP, and you don't have to try and remember what happened 3.5 weeks ago on a Tuesday afternoon. Like, you can remember, like, you can just look in and show them, and then and you can then show, right, this is how it looks like when it's really bad, this is when it's sort of medium, and today is a better day, and seeing you like that.
Yeah, that's really helpful. And we'll also put together maybe some resources and some links to support groups in the UK that you mentioned for the webpage that will go with this episode as well, just in case people want to look that up. So I guess finally, before we finish, do you have any recommendations for our listeners if they want to find out more about this topic that we've discussed? So this could be other academic articles, could be pop science books, podcasts, anything you think think might be helpful?
Yeah, I mean, there's probably so much out there. I think you can look at like NHS resources and see what's out there in terms of guidance about what to do about chronic pain. I think people would even just start there because most of that is built on academic articles and research. But there is quite a lot of research out there now written with people with lived experience and how we're working with people with lived experience to develop the strategies and tools. And so maybe you would read some of those types of articles. So you'll see things like community engagement or community partnerships or something called patient public involvement and engagement. So if you're searching for articles, maybe pain and those things, so you can sort of see what I think are sort of more becoming a gold standard of how we should be doing work. It shouldn't be done. The famous phrase is nothing about us without us, right? So if we're doing that research, it should be with individuals who are experiencing that. So I think those would be the articles I would have people go towards. And then there are large charities who are doing work with groups that are experiencing pain. So Versus Arthritis comes to mind, Sickle Cell Society here in the UK. So if you have specific types of pain, but if fibromyalgia or headache, there are actual charities who are specific to those, and so I would look and go on to their websites as well, so you can experience and look at that as well.
Brilliant. We will link some of those. And as I mentioned before, our part 2 of this series is talking about a healthcare program for people with chronic pain, and that was co-designed with Black people with chronic pain living in London. So exactly what you said, patient and public involvement. This is where the researchers and the healthcare professionals say, okay, what do you need from us and how can we design this healthcare program to make sure that we're supporting your needs? And at the same time as bringing in all the evidence from the biopsychosocial model, all of these different streams of evidence. Seems like a very important process.
Yeah, I mean, it's still, I think we're doing much better at it. We're doing better than we were 5 or 10 years ago. We still have a long way to be even better. But yeah, co-designing things, co-producing. So it's actually designed in that the questions that people are answering. So, your very first question to me was about my detour. That was a detour that was because people were saying, this is actually the research question we're interested in. The other thing you're doing is interesting too. It's nice, but this is actually the really thing. And so that's part of co-production, is actually listening to the people who are experiencing a particular condition, in this case, pain, and them saying, this is the thing that we're interested in, and then actually making change on that. And that can be harder for researchers because that's not how we're trained. We come up with an idea and then we go out with it. And actually saying, though, I'm an expert in what I bring, but you are the expert in your experience of pain. And how do we work together and create something together that then actually, will work for the community? Because, that should be our only goal, really, is that we work for the communities that we serve.
I think that's a really nice note to end on. Working together for the communities and to meet people's needs. I think that's really nice. Thank you so much for coming on to the podcast today. I've learned a lot about your work, about inequalities in chronic pain, and I think there's lots of snippets in there for people to kind of even better understand maybe their own experiences, their friends and family's experiences, and where to go next or where to start with trying to seek support.
Great. Thank you. Thanks so much for having me.
Thank you so much for listening, and thanks again to Anna for coming on to the podcast today. Make sure you sign up to the newsletter at scienceorfiction.co.uk to catch our next episode and part 2 on chronic pain, and a recent healthcare program designed to support diverse communities in chronic pain management. As always, you can find links to the research and resources that we talked through today on our website as well. You can follow us for updates and more information on Instagram and TikTok at Science or Fiction Podcast, or on our LinkedIn page, The Science or Fiction Podcast. If you want to get in touch or you have a suggestion for a future topic, we're always keen to hear from you. You can email us info@scienceorfiction.co.uk or DM us on social media. Thank you to Mariam Shah for producing these chronic pain episodes, the Young Person Advisory Groups for their input on this series, and to Kit Studio for the branding and Jamie Johnson for the music. See you next time.